Good afternoon. My name is Justin Heckman. I'm a third year medical student, and this is my EBM assignment. So, the paper that I was assigned to analyze was surgeon-driven preoperative psychiatric evaluation of plastic surgery patients. So, let's get started. So, what type of study is this? This paper was a retrospective cohort study, and what that means was that they took a bunch of papers and notes from the previous couple of years, specifically between June 2010 and June 2016, and they essentially analyzed those notes. So here on our triangle with all the different types of studies, you can see that retrospective cohort studies are known as observational studies. So it's mainly to draw conclusions from it. Now, it's above non-human studies, but it's below meta-analysis and other interventional studies where you have like randomized control trials. So in this specific paper, we saw elective plastic surgery patients that were referred by one single consultant to a psych assessment. And it was known as the Flinders Medical Center. That was the main area that this study was taking place in. So, what is the study trying to address? The study is trying to estimate the rate of psychiatric disorders in plastic surgery patients. Now, when we have plastic surgery patients, it's a little bit difficult to weigh whether the person is coming in because they would like to have some sort of change on their body or if it's some sort of mental illness. And this paper is trying to address that discrepancy. So they also wanted to estimate the types of psychiatric disorders. Now, most surgeons fear BDD. BDD is body dysmorphic disorder, and body dysmorphic disorder is well, I shouldn't say feared. It's more of something that we shouldn't operate on because it's the actual area of issue is more a mental disorder than a physical issue that needs to be corrected. Then afterwards, we have describe how surgeon and integrated psychiatric models of care changes decisions about whether patients go to surgery and what psychiatric treatment they receive. So overall, this paper wanted to make sure that we had the correct way of treating patients, especially patients that are coming in for an evaluation of plastic surgery. So there's three ways that the surgeons could handle a patient. They could either send them off to surgery and then send them on their way. They could send them and refer them to a psychiatric unit, or they could do the surgery and also have a psychiatric evaluation at the same time. So we have to take those into consideration. So who was in the study? This was a public hospital in South Australia, and all patients seeking elective plastic surgery were in between June 2010 and June 2016 were chosen. And the plastic surgery surgeon that was doing this then referred them to a psychiatric liaison between them. So in total, 88 patients were in this study, and 65 of them went to the psychiatric assessment. Now, out of those 65, 87.5% were female and 12.4% were male, and the majority of them were between 19 to 50 years old. And there was a complex number of surgeries. This was including rhinoplasty, abdominoplasty, breast augmentation, blepharoplasties. Any type of surgery was included in this. Now, the prevalence of mental illness after they went to the psychiatrist was 54 of 65 of them received a diagnosis. Now, there were multiple diagnoses that they could have had, but they were a couple of main things that were seen. First of all, major depressive disorder, post-traumatic stress disorder, and other specific disorders like eating disorders, anxiety, and personality disorders. Now, BDD was also prevalent. And BDD is, as I mentioned, one of the main things that plastic surgeons look at because body dysmorphic disorder is a mental illness rather than a physical change that you can do and have the mentality of the patient improve. So 87.7 needs some sort of psychiatric care. That's the percentage of overall of these 54 patients. Among those with good or moderate physical indications for surgery, 75% of them ultimately had surgery. So the surgeon evaluated them, said these guys are good candidates for the surgery. And so 45 out of the 60 received the surgery that was necessary. Many of these had combined care, surgery, and psychiatric treatments. So out of those 45, 35 of the 45 had planned combined surgical psychiatric management approach where they had the surgery and they were also consulted by the psychiatrist and treated for their condition. Now, moving on to the body dysmorphic disorder. This is where the surgeons were trying, and well, the paper was trying to focus on because this is a tight subset that needs to be analyzed. Now, 9 patients had BDD. 6 underwent surgery, and 4 of those continued psychiatric care afterwards. 3 did not undergo surgery and were treated with cognitive behavioral therapy. Now, those 3 actually had great improvements overall on their perspectives of themselves. There was a specific anecdote that I would like to go into right now, where there was a patient that had a traumatic facial injury. They received multiple surgeries. The traumatic facial injury came from a tractor accident. But what they noticed was this person had body dysmorphic disorder on top of the deformity. So they had to do the surgery, they had to do the cognitive behavioral therapy, and overall, it had a very good functional and psychological outcome because the patient was able to heal from their trauma, and also their mind was also able to heal from their body dysmorphic disorder. So the overall conclusion of this is that surgeon-driven psych referral picked up a very high rate of psychiatric illness and allowed either combined care or a diversion away from surgery when was appropriate. So the surgeon referred them to the psychiatrist, and the psychiatrist determined if it was an actual physical issue or it was a mental issue. And it showed that both the combination of the surgeon and the psychiatrist are overall a good thing for patient care. And this was the example I was talking about. This was the lady that was in a tractor accident, and these are the reparations that occurred on her face. And as I said, she had good care from both her surgeon and her psychiatrist. So what are the outcomes? So as I mentioned, 65 of the assessed patients, 54 of them received a psychiatric diagnosis. The most common diagnosis was MDD with 19 patients, PTSD with 19 patients, and then a variety of eating disorders, anxiety, personality traits. Now, BDD, 9 of 5 of the patients were diagnosed with the BDD, and that's what I mentioned in the previous slide. And the need for psychiatric care, 87.7% of the 65 were needed for some sort of psychiatric care before or after surgery to make sure that the outcomes were good. Now, among those with a good or moderate physical indication, I mentioned 45 of them, they had surgery. Many of these, 35 of those 45, had a planned combined surgical psychiatric treatment. And so these outcomes overall showed that these patients did well overall with the combined treatment. The BDD subgroup, as I mentioned, 6 underwent the surgery, then 4 of those went to psych care, and then 3 of them just had CBT. And they had good outcomes, and the 3 that didn't have surgery did not go back to have surgery. They were able to improve so much that they felt that whatever deformity they had was improved. So again, the conclusion is that combined care and a diversion away from surgery is necessary, and combining both surgeons and psychiatrists are necessary to evaluate these kinds of patients. So, can we generalize this to the real world? Now, the real thing is it's partly generalizable. It supports the idea that plastic surgery patients flagged as concerning by surgeons, and a larger fraction of these patients that surgeons catch will have mental health issues, and the psychiatrist can be helpful. And this is extremely applicable to all plastic surgery services because if you have a public setting, you need to have a psychiatrist on board. So it's real world relevant, but the percentages and the pathways may not apply universally because we have to think about, first of all, it's Australia. Second of all, there was only about less than 100 patients. So what limits this generalizability? It's a single center, single main surgeon that determined this. This is completely subjective. There weren't multiple surgeons. There wasn't a psychiatrist that would check all of the patients. That's another thing. There was a selected subgroup. So only the patients that were referred went to the psychiatrist. So we don't know how well the surgeon actually was able to find these mental illnesses. And the other thing that limits generalizability is that this is an Australian system and we live in an American system, and that's a little bit different. So, what are some strengths and limitations of the study? The strengths were it was a clinical cohort in a public hospital that reflected real practice. The clear description of the practical model of care was surgeon driven, and then psych referrals were integrated. There was a detailed chart review. Indications were seen by the surgeon, which determined whether it was a good, moderate, or no physical indication, and included a breakdown of BDD cases and illustrative cases. And it shows overwhelmingly that feasibility and acceptability of high attendance and treatment compliance suggests psych referral does not destroy the doctor-patient relationship. This was one of the main concerns that most surgeons have because they don't want to refer them to a psychiatrist, and then the patient's like, oh, well, if he's not going to do it, I'm going to go find another doctor to do it, and he's just calling me crazy. So this stigma that was previously thought to exist showed that most patients do want to have help. They do want to feel better about themselves. Now, of course, there's going to be limitations. The retrospective design shows that there's missing data, documentation bias, and we didn't interview any of these patients. We didn't interview the doctor. We're only seeing the notes that existed. There's selection bias and limited sampling frame, so there was less than 100 patients. It was referred by one single surgeon to a psychiatry unit, and there was no standardized referral criteria, so we don't know the entire pool of plastic surgery patients. And then that's the other thing. It's single surgeon and single center, which limits external validity because we have multiple hospitals with multiple settings with different ethnic groups that the you can't apply it to everybody. We know this works in an Australian system, but we don't know what the nuances are going to be in an American system. There's also other limitations about the actual study. There wasn't a control group, and there's no prospective outcome. So there's no comparison with similar patients to see if the psychiatric evaluation was actually beneficial. And there was no pre or post measures of quality of life, except for the body dysmorphic disorder, because that, again, was the main concern of the surgeons. And there was also no incomplete follow-up because overall, the hospital's electronic record ended when the patients stopped going to the psychiatric unit. So they might have had surgery somewhere else, or they might have had psychiatric care elsewhere. They might have been completely dropped from the system, and we wouldn't be able to know. So overall, that concludes my EBM assignment. It was a very interesting paper. I have included the citation for the paper if you guys would like to read it. If you have any questions overall, you can always contact me here at my email, and here is my phone number. Thank you very much. I appreciate everything that y'all have done, and I will see you guys later. Bye. Thank you.